As we all know, God Almighty has created the world in the best possible way, and human being is one of his finest creations, most intricately designed and programmed. And to visualize this beautiful world, we've been gifted with the invaluable gift of our eyes, our special sense, the vision. In any case, if our vision goes dim, goes light, goes affected, if there's an abnormality in either of the eyes, if there is any transparency loss, if there is a discrepancy in our vision, our lives change 24 clocked around. So, to discuss this issue, we have our presentation today as an approach to a case of sudden loss of vision, to listen to which we are very privileged to have amongst us our eminent speaker. He is Professor Dr. Gyanendra Lamichhane, acting as the retina or uvea and cataract specialist and the chief medical director at the Lamichhane Eye Institute, Nepal. And to chair this session, we have amongst us Dr. Murtaza Nuruddin. He is the consultant ophthalmologist and director, Academic Chevron Eye Hospital and Research Center, Chattogram, Bangladesh. So without further ado, I now please request our honorable chairperson to inaugurate the session. Sir, would you please say a few words for
Thank
all
you,
of us?
thank you, Dr. Aisha. Today's topic, sudden loss of vision, the approach to sudden loss of vision, is a very important topic, I believe. Vision is very important component of our life, and sudden loss of vision is an ophthalmic emergency. Various causes of sudden loss of vision are there. I think we will come across those causes in few minutes. First of all, let's have some knowledge on this. And then after that, we will discuss further how we can proceed and how we can promptly manage all these cases. Particularly here, all the physicians are there. And sometimes patients with sudden loss may present to them, and how they can manage immediately and how to refer to the appropriate place. This should be a very important thing to preserve patient's vision. So let's have uh, this important topic, presentation on this important topic. Professor Gyanendra, I think you can start now so that we can have a good discussion after that.
Thank you, sir. Thank you, Dr. Ayesa. Let me share my slide first. Okay. So, good evening, everybody. First of all, I'd like to thank BG Physician entire team for giving me this opportunity. As I am aware that this is a diverse group, we may have physician and other specialty as well. So, being an ophthalmologist, I am trying to make this presentation very comprehensive and very simple so that we can understand the basic things. The main aim of my today's session will be to provide a comprehensive overview how to approach to a case of sudden loss of vision. Secondly, we'll have some brief discussion on common causes. Mainly, I will focus on ocular causes, and we'll try to conceptualize to localize the probable site of pathology, and I will try to discuss few common case examples. So this is a very basic slide. Let's understand how do we see the things. So we all know from our MBBS knowledge that we have, whenever a ray of light falls in our eyes, it have to pass through the refractive media, which comprises of from cornea up to the retina. And in the retina, especially in the fovea, the image of that things will be formed, which will be carried out by optic nerve toward the brain and visual cortex, and will able to perceive the things. So you can see in this schematic diagram as well. This is the one very old things which is very easy to understand, because we compare human eye as a camera, and whatever the image formed in the camera film is inverted, which is exactly same as that which is formed in our retina, and through the optic nerve it is carried out to the brain and it forms the real image. So whenever a case of sudden loss of vision encounter to us, what are the first four important questions which we must ask ourselves to narrow down our differential diagnosis and to cleanse the diagnosis? The first one, we have to find out whether the sudden diminution of vision is in one eye or in both eye. Why this is important, I am going to discuss shortly in my next slide. Now, second point is whether the sudden loss of vision is painful or painless. It also helps to cleanse a little bit narrow to our differential diagnosis. Our third questions would be whether the sudden loss of vision is transient, that is less than 24-hour duration, or it is persistent more than 24-hour of duration. And fourth one is is there any associated symptom along with this sudden diminution of vision? That means it is purely related to ocular symptom only or associated with other non-ocular symptom. So these are the four things I think we shouldn't miss whenever we approach any cases of sudden diminution of vision. So let's see our first, what is the importance of being one eye versus both eye diminution of vision? Because if there is sudden diminution of vision in one eye, most of the time the cause lies within the eyes or optic nerve anterior to the chiasma. When there is sudden diminution of vision in both the eye at the same time, that signifies that the cause we have to search beyond the eyes, that is either beyond the chiasma, and usually it is related to the vascular pathology. Yes, definitely there are certain conditions where there is bilateral diminution of vision in both eyes and still the cause lies within the ocular disease itself, such as VKS syndrome, which I will discuss later on in one case. So you can see this slide. If it is a sudden diminution of vision monoocular, usually if it is painless, is usually signified the vascular cause, whereas there is painful, it may be your acute angle closure glaucoma, may be associated with optic neuritis. Wherever in right side you can see there is, if there is binocular loss of vision, usually the causes lies beyond the eyes, that is it may be the chiasmal dysfunction, it may be the occipital dysfunction and other things which is centrally located. And our second question, whether the diminution of vision is painful or painless. So we can see here the long list of things. In the left side you can see if it is painless sudden diminution of vision, then usually it may be the central retinal artery occlusion, it may be the massive vitreous hemorrhage, retinal detachment or ischemic central retinal vein occlusion. Whereas if there is sudden diminution, defective vision, not the loss of vision, there are certain ocular conditions where vision is not profound loss but some sort of defectiveness is there. Whereas if there is sudden painful loss of vision, it is usually signified acute angle closure glaucoma, maybe acute iridocyclitis, chemical injuries and sometimes maybe mechanical injuries to the eye. And in history, what to ask? So as I have already mentioned, you have to ask associated history or symptom to localize whether it is purely ocular or beyond the ocular. So you have to work up accordingly. Any history of trauma, any history of flashes or floaters, which is usually signifying the retinal detachment, any history of visual distortion before sudden diminution of vision, and amaurosis, history of amaurosis, such as transient vision loss, which usually signifies the vascular causes, any history of nausea and vomiting associated with diminution vision, which usually signifies the raised intracranial pressure or maybe raised ocular pressure, and any history of headache, jaw claudication and scalp tenderness. And third one is transient loss of vision. Whenever we encounter a transient loss of vision, we have to find out the age is one of the important factor, because if it is usually below the 40 or 40 above the 45s, it usually signifies the ischemic cause. Similarly, onset of transient loss of vision is also important, because if the transient loss of vision is over the second, it usually signified embolic and vasospastic phenomena. Similarly, duration is also important. You have to ask the patient how long the transient loss of vision is lasted. If it is only for seconds, it usually may be the orthostatic hypotension or ocular cause. If it is from minutes to hour, it may be the migraneous attack or like that. Similarly, monoocular, binocular, as I have already mentioned. And examination, if you ask me what to examine in case of sudden diminution of vision, the simple answer, you have to examine everything. couldn't leave any system as per finding. For example, initial visual acuity is equally important because it signifies the prognostication. That means if initial visual acuity is poor, the prognosis is itself poor, and if the initial visual acuity is good, the prognosis is considered to be the good in long term. Similarly, pupillary reaction is very important. You have to see whether it is afferent or efferent pupillary defect, and you have to do detailed ocular examination, retinal examination. Sometime you may encounter the case where there is diminution of vision in both eye, but the retina ocular finding looks absolutely normal. This signifies usually the central cause. Then you have to do the optic nerve examination, fundoscopic examination, whether the optic disc is swelling or normal disc usually occur in retrobulbar neuritis. Similarly, confrontation test, which we all know it's a rough estimation of visual field changes. Then color vision, intraocular pressure monitoring, and ocular motility is equally important, whether it is restricted or non-restricted, it is painful or not, and neurological assessment as per your requirement. So these are the simple ocular motility tests we usually have learned from our MBBS knowledge as well. Similarly, the confrontation test, it gives us a rough guideline about the visual field status of the patient. And another important thing is you should do the test for pupillary abnormalities. There are different types of pupillary abnormalities. There are some afferent defect like total afferent pupillary defect, which we call as amerotic pupil. There may be the relative afferent pupillary defect, which usually signifies the partial optic nerve lesion. Similarly, Wernicke's hemianopic pupil usually occur in optic tract lesion. Or similarly, you have to see about the efferent defect. Then testing for RAPT, which we usually call as the swinging light reflex, in which there is a paradoxical dilatation of the affected pupil. And Ishihara chart, it signifies the color vision testing. So another question, so when to refer the patient? If we see the patient of sudden diminution of vision and without any neurological symptom, and you see in this condition, I think ophthalmologists can handle the condition. But if you see the case of sudden diminution of vision and associated neurological symptom, it may be weakness, numbness, and other things, I think it's better to take opinion from your neuro-ophthalmologist or neurologist colleague. And these are the simple basic investigation you can tailor depending upon your clinical finding and examination. And we should never forget about malingering. Sometimes what happens, patient may refer to you for sudden diminution of vision and you found everything looks to be normal, including your pupillary reaction. And in that set of mind, you should always think of malingering in the back of your mind, because sometimes patient may pretend to be blind because for the sake of some benefit, maybe anything or like that. So there are certain subjective and there are certain objective tests for malingering. There is eye contact test, obstacle test, finger nose test, lens fogging test, and other tests which you can do in your office setting to differentiate between it is true diminution of vision or patient is malingering. Beside this, there are some objective tests like as I have already mentioned, pupillary reaction, optokinetic nystagmus, and in some case you can do the visual effect potential test. So I would like to highlight some of the common scenario in our clinics. This is our first case, about 60-year-old patient with a history of heart disease. He presented with sudden painless diminution of vision in the right eye. So if you just remember my previous causes of sudden painless diminution of vision, then you can come to a diagnosis. So on fundus examination, we can see there is a cherry red spots you can appreciate in your left figure, and there is a retinal whitening, and there you can see the arrow-headed, there is a segmentation of the blood column. So what should be the probable diagnosis? So it is a case of central retinal artery occlusion. It is one of the ocular emergency. And we should do the suggested vascular workup for the patient with CRAO, because blood pressure hyperlipidemia, and carotid artery occlusion may be the some of the common causes for your sudden diminution of vision due to the central retinal artery occlusion. And there are different type of emboli as described. There may be the cholesterol emboli, where you can see in the top right figure whitish lesion at the bifurcation. There may be the calcified and fibrinoplatelet emboli. And giant cell arteritis is one of the commonest cause in old age population, and sometimes you have to rule out the other collagen vascular diseases, hypercoagulable stage as well. And usually the treatment outcome of central retinal artery occlusion is not that much favorable, whatever treatment you are going, because if the patient, because the retinal ischemic time is almost 45 to 90 minutes, after that it may cause permanent damage to the retina. And there is also the high risk of stroke to the patient who have developed the central retinal artery occlusion. You can see from the data about 8.5% versus 0.8% control risk to develop the stroke in future. Let's see our second case. It's a 50-year-old male patient with a history of hypertension. He again present with the painless sudden diminution of loss of vision. So if we compare to our previous, the history and presentation looks same, but the clinical picture is entirely different. Here you can see there is a retinal hemorrhage in all four quadrants of the retina. So it's a case of central retinal vein occlusion, and the common predisposing factor is a hypertension and diabetic. So these are the picturesque difference between the CRO and CRVO, which you can just differentiate by seeing the picture as well. So vein occlusions are usually due to thrombus, whereas arterial occlusion are usually due to emboli. Our third case is 45-year female with sudden diminution of vision in one eye associated with redness, eyeball pain, headache and vomiting. And if we see the intraocular pressure, it's in right eye, it's about 40 millimeter of mercury. As we all know, the normal range of intraocular pressure is 10 to 21. So this is a case of acute angle closure glaucoma. It is one of the ocular emergency. So sudden diminution of vision may present in that way. Our fourth case is 50-year male with a diabetic for 14 years under medication. He complained of sudden diminution of vision in one eye and no history of trauma. So this is a case of vitreous hemorrhage due to uncontrolled diabetes and no treatment of diabetic retinopathy previously. Our first case is another cause of sudden diminution of vision in left eye for 5 days, and the clue to this diagnosis is patient has history of flashes few days prior to diminution of vision. And in this picture we can see the superior retina is whitish. We can see some retinal fold with retinal breaks. So it is a case of rhegmatogenous retinal detachment. Our sixth case is 65-year male with sudden diminution of vision in right eye 2 weeks. So he is a case of chronic smokers. And if we see the fundus photo, you can see in the right eye there is arrowheaded. You can see the clumps of blood you can see in the posterior pole. And it is one of the leading cause of adult blindness in Western world. We all know that in this South Asian subcontinent, the commonest cause of diminution of vision in adult is the cataract still. But in Western world, this wet age-related macular degeneration is one of the causes for blindness in adult population. So is the patient treated later with the anti-VEGF injection in the eye. So the seventh is more important. It is related to both eye as well as neurological. So let's see this case. It's a 42-year male with sudden diminution of vision in one eye. So pain on eyeball movement, pupil and color vision are defect, and we can see in this picture there is swelling of the optic nerve head, that is optic disc, and we can see some hemorrhages around the margin of optic disc. So if we see that picture only, the two possibilities comes in our mind. One is the papillitis, another that what is a form of optic neuritis, and another is the papilloedema. So we should sometimes I see the people usually get confused to differentiate between papilloedema and optic neuritis, which is very important to differentiate in our scenario. So there are different causes of unilateral as well as bilateral swelling of the optic nerve. So you can see that exhausted list as well. So if you see the optic neuritis, it is usually basically three type of optic neuritis. The first one in picture you can see there is a retrobulbar neuritis. From the name itself suggests the pathology is behind the eyeball. Usually we used to say the patient sees nothing and the doctor sees nothing. That means patient complaining that he has sudden diminution of vision. On retina examination, eye examination, everything looks normal. So this is maybe the case of retrobulbar neuritis. And the commonest cause is the demyelinating disease, especially multiple sclerosis. In second form, what I saw in previous slide was the papillitis type of optic neuritis, which usually follow after the viral infection, and demyelination is not that much common. And third variety of optic neuritis is your neuroretinitis, that is papillitis with macular scar, which usually seen in various other diseases as well. So this is the important slide to how to differentiate between papilloedema and optic neuritis. So the basic difference is that papilloedema is usually bilateral. The first thing is it is usually bilateral, whereas optic neuritis or papillitis, it is usually unilateral. And papilloedema vision is absolutely normal till the late stage, whereas in optic neuritis there is severe reduction of the visual acuity. And another important examination is the pupillary reaction. What we can get in papilloedema, pupillary reaction usually normal, whereas in optic neuritis or papillitis there is a RAPT. So these are the common difference. There are other difference as well you can see in that slide. And the basic cause of papilloedema may be the space occupying lesion. So we have to do the CT or MRI to see any intracranial space occupying lesion, whereas optic neuritis usually demyelinating disorder, as I have mentioned in my previous slides. And another term is the arteritic anteroischemic optic neuropathy and non-arteritic ischemic optic neuropathy. The AAION usually occur in giant cell arteritis, or what we call is temporal arteritis, whereas NAION usually occur in diabetes, hypertension, or sometimes maybe obstructive sleep apnea. And usually AAION occurs in the older age group of population above 7th decade, whereas NAION occurs in 6th to 7th decade. And there is history of jaw claudication, scalp tenderness, and sometimes maybe the fever in AION, which is very raised high ESR. So we are all aware about this visual field defect. So I am not going to discuss detail about this defect. So my 8th case is 45-year male with sudden diminution of marked diminution of vision in both eye 3 days with associated with headache and tinnitus. So if you can see in this fundus photograph, you can see there is multiple pockets of subretinal fluid in the retina, which in the middle photograph you can see OCT, you can see the blackish area, there is a fluid accumulation in the retina. Though I have already mentioned in my first slide that if we see the bilateral sudden diminution of vision in both the eye, the causes usually lies beyond the eyes, but still we should be mindfulness that there are certain ocular conditions where there may be the causes of bilateral diminution of vision. So though it is a systemic disease as well, so this is a case of Vogt-Koyanagi-Harada syndrome, and patient was admitted and treated with IV pulse methylprednisolone followed by oral steroid and systemic immunosuppression. And if these cases we fail to identify and patient receive only inadequate treatment, then this may lead to this is what we call as the sunset glow fundus, and ultimately may lead to the permanent vision loss. So we should be mindfulness to detect this case earlier for prompt and initiative treatment. And my last case is one interesting case. It is a 12-year-old male with sudden diminution of vision in both eye for 2-week duration, and he has no previous illness. And once we see the fundus photograph, we suddenly think something that is not happy for us. Because in young boy with subhyaloid hemorrhage and retinal hemorrhage in both quadrant, we should be alert. So we think the patient has hepatosplenomegaly as well. So we send blood count and it come to be the very high white blood cell count with blast and peripheral blood smear. So it turned to be the case of leukemic retinopathy. The patient was previously unaware and undiagnosed about the leukemia, and as he complained of sudden diminution of vision and presented to us to the ophthalmic department, and we are able to point out this life-threatening disease to the patient. So my concluding slide is summary in whenever we are approaching to a case of sudden diminution of vision, so we should take detailed history and careful clinical examination. This will narrow down our differential and will cleanse up to point toward the right direction of our management and diagnosis. And make sure that patient is not malingering and it is a true case of the sudden diminution of vision. Third one, if it is a unilateral, the cause is usually lies within the eye, whereas it's bilateral diminution of vision, the cause less likely to be the ocular causes, usually systemic and vascular or neurological causes. And always do ophthalmic examination, and sometimes it may be the normal, do visual field testing, think of visual pathway lesions. In such condition, eye examination may be normal. And don't miss the stroke risk, systemic risk factor, and temporal arteritis. Because though we are ophthalmologists, we have to treat the patient and examine the patient in a holistic approach. And as per my last case, sometime it may be associated with the life-threatening conditions. So it is very rewarding that we could find out such life-threatening conditions and do the early referral and management for the case. So thank you very much for your patience learning. So for everybody's kind information, this is our MBBS time. So I was very proud to be the graduate from USTC Bangladesh. So we are 1999 to 2003 batch. So thank you once again, and I'm happy to take any question if any. Thank you.
Thank you, Gyanendra sir. It was an excellent session, and we're immensely privileged to have you amongst us as our mentor today. And before moving on to the question answer part, I kindly request our honorable chairperson, Murtaza sir, to pass brief comments regarding the presentation, sir. Murtaza sir, kindly session নিয়ে দু একটা কথা বলবেন সবার জন্য।
Thank you very much, Dr. Aisha. And thank you very much, Dr. Gyanendra. It was very nicely presented. A very big topic is precisely presented in a very simplified manner. And I think our audience must have gained some knowledge from this presentation. I want to say something about the sudden loss of vision. The sudden loss of vision is actually an ophthalmic emergency. Whenever there is sudden loss of vision, it has to be diagnosed very promptly. It has to be treated very promptly. Many cases with sudden loss of vision can be recovered, though not fully, but partially, if we treat it properly. Some cases like central retinal artery occlusion, it is really very emergency. And as Dr. Gyanendra said, that if we cannot treat such cases within 40 to 60 minutes, retinal hypoxia occurs. So I have not seen any central retinal artery occlusion promptly recovered. If it is spontaneously, sometimes this lodged out and then it can recover. But we can try ocular massage and other options immediately, but hardly there is recovery. What we can do, sometimes here in Bangladesh, we come across some of the patients with bilateral vision loss, acute vision loss, that is particularly আমরা যেটা বলি চোলাই মদ, বাংলা মদ যেটা খায়, হ্যাঁ, that is an important thing. So this is also has to be treated very urgently. Otherwise, most of the cases we can't recover such cases. Particularly we treat those cases. Sometimes these cases go to first to our physicians. And if they can treat it properly, particularly with methylprednisolone, then I think we can improve such cases. I just want to share one of my experience about a patient. One patient having vomiting, headache, and abdominal pain. She was admitted in a clinic, and she was treated for vomiting, for abdominal pain. Unfortunately, the attending physician did not ask about her vision, did not look at her eyes. It was actually red eye, and it was painful eye. Sometimes angle closure glaucoma may present as abdominal pain, headache. So we have to think of that also. Okay, so mostly many of our audience are physicians. So I would request them that whenever you get any patient, at least, okay, and ask about the vision. Actually, eye is a mirror of many diseases, so we can go across such diseases. Another one is like optic neuritis. Mm, it can be treated with some time, but it is also an emergency sometimes. uh, Dr. Gyanendra has very nicely differentiated about between papillitis and papilledema. So um, and other thing, yesterday only I come across the patient, a young girl with bilateral visual loss. Parents were very anxious, but ultimately it was revealed as malingering. So this is also an important thing. We have to look for it. We have to look carefully. We have to examine carefully. I think so many causes of sudden loss of vision. The whole night will pass on with this topic. So I think if there is any question from the audience, Dr. Aisha, you can ask for questions so that uh, Dr. Gyanendra and myself make an answer.
Sure.
The audience is kindly requested to ask live questions to make the session more lively. I can see one hand raised. Dr. Yusuf Ali wants to share maybe something. Could someone please unmute Dr. Yusuf Ali?
Dr. Yusuf.
Dr. Yusuf Ali, you're live. Please raise a question.
Okay, thank you very much for giving me the chance. Actually, it was an excellent session for especially clinician. And the neuro-ophthalmology is very much crucial for every postgraduate doctor. It's a excellent presentation and case shown by the presenter. It was wow, wonderful and very much practical in our day-to-day life. Actually, this patient initially many disease, sir has rightly told that that is fundus or eye is the mirror of many systemic disease. I have a question that many sometime we very much face difficulty in diagnosis of is it early papilledema or any optic neuritis. Sometimes yes, optic neuritis sometimes painful, and when we do fundoscopy we get very much just hyperemia of the disc, and hyperemia, and it's very much sometimes difficult to say that is it early papilledema or optic neuritis. And it's a I don't know, ophthalmology sometimes label it as papillitis. So how can we differentiate that? There is early papilledema and optic neuritis or papillitis.
Should I answer this? Okay. Okay, so thank you for your questions. I think before going to that, I will just like to share one of my experience with my patient. It was about 1 year back. One of my patient came to my clinic with the history of sudden blurring of vision, and at that time the patient's vision was 6/6 in the both eye. And what I did the pupillary examination. There was RAPT present, but vision was absolutely 6/6, and I think it's okay. Vision is 6/6, nothing to do. Disc absolutely looks normal, and I sent the patient back. And patient came 1 week after with the hand movement vision, with a frank disc edema, okay, papillitis. So what we can, most important thing to differentiate between two things is, first one is pupillary reaction. That is very much important. Pupillary reaction we should never miss in any cases of diminution of vision. That is one thing to cleanse, differentiate between early papilledema or papillitis or retrobulbar neuritis, whatever you think. Second is the contrast sensitivity, which I not include in that session. Another one is contrast and color sensitivity. These are the two important things I think we should differentiate between two things. And because what happens in case of optic neuritis, their visual acuity may be more or less normal, but what happens, the color or contrast is markedly reduced in compared to visual acuity. So these are the few things that may lead you to differentiate between early papilloedema and papillitis. I think Murtaza sir can add something in this.
Yeah, you have rightly said. Color is a very important thing. Color and contrast. At least if we ask the patient, suppose the color, as per example, if it is red color, bright red color, the patient will appreciate it as a light red color.
Exactly,
So
exactly.
yeah, so patient, this is very important thing we may ask. And in dark light, dark room, we have to examine the pupil, particularly for Marcus-Gunn jaw winking, Marcus-Gunn pupil. So Marcus-Gunn pupil is what is RAPD. If we see there is RAPD is present, that means it's a case of optic neuritis. In papilledema, we don't see RAPD. Okay. Sometimes vision might be normal in both the cases, but we have to differentiate with particularly. Then another thing is light appreciation. Light sensitivity is also reduced in optic neuritis. So all these things are very important, which we say
Okay.
as optic nerve function tests. Okay.
Yeah.
Yeah.
Thank you, sir. Recently, I encounter a case that is subacute onset of headache and the bilateral loss of vision. Later on, I am facing difficulty in diagnosis about bilateral optic neuritis, and ultimately that case was diagnosed as case of giant cell arteritis. And giant cell arteritis, uh, uh, is a usual presentation with bilateral AION. Is it unilateral or bilateral? What is the
What was the
percentage?
age
Or
of your patient? What was the age of your patient?
around more than 50,
And and
around 60 years of male patient was
okay,
headache.
how did you diagnose it at Jansel arteritis?
So
What were your
ultimately, the presentation was a headache, that is
wha-
bilateral loss of vision, and there was a features of, even there was features of myelitis. That is, patient presented with also paraparesis, and ultimately other features suggesting by exclusion. Okay, the diagnostic criteria of giant cell applying, although we could not confirm it by doing biopsy, but ultrasound we reveal these things. That is.
what about the ESR? What about the C-reactive protein?
Yes,
Did
sir
you do?
was high. Yes, sir was 55 around or 60,
Mhm.
not much so high, but it was moderately raised. Yes, sir. Okay.
Okay. So it's sometimes very difficult to say actually. Giant cell arteritis is not that common in our region actually. So in aged person, if the patient presented with headache, with bilateral anti-ischemic optic neuropathy, with jaw claudication, uh, the main thing for giant cell arteritis is promptly. Sometimes it presented as a unilateral presentation, and rapidly it may turn into bilateral. So the prompt treatment means methylprednisolone. But before giving methylprednisolone, we have to do temporal artery biopsy. So this is the most important thing. Once you give internal methylprednisolone, you will lose the features in histopathology. So the prompt management is biopsy and immediately starting methylprednisolone without waiting, without the report even. I'm not sure whether your case is giant cell arteritis or not, but in case of giant cell arteritis, there will be raised ESR, there will be high C-reactive protein and other clinical associated features like that.
So I like to make a few comments on that case. Whenever you usually optic neuritis or papillitis is usually a unilateral conditions, but whenever you see from as your patient history bilateral optic neuritis with paraparesis and all these things, you should be think of atypical optic neuritis. That is called NMOST, NMO spectrum of
Yeah.
disease. Okay, so it is a auto antibody against the aquaporin channel and all these things.
Yeah,
So
it was done. It was negative. It was
okay,
done. Okay.
usually these are the condition. Otherwise, Suarez nicely explained that as well. Thank you.
Yes, thank you, Dr. Yusuf Ali. Both our teachers have very well elaborated their answer to the question. So now let's take up a few questions from the chat box. So one of our doctors has rightly asked, what should be done in a GP setting if a patient presents with sudden loss of vision?
I think we have mentioned in all these things. First of all, you should never forget. I mentioned you 4 steps initially. You should find out whether it's a very simple thing. It is unilateral or bilateral diminution of vision. Okay, then you should do no painful or painless diminution of vision. You that can do, and never forget to do a pupillary reaction, pupillary examination. I think that everybody can do that. So these are the few things you can set in, and if you are quite familiar, you can do a simple direct ophthalmoscopy examination, which everybody can do. So these are the few things I think we can do in a GP setup, as per my.
The important thing in GP setup actually, in our GP setup, it's the facilities are limited. It's very difficult to diagnose even. The main important thing for a GP is to convince the patient that it is an emergency and you should go to the appropriate place immediately without wasting any time. So counseling is very important. That is, yes, it is important and you should go first. That is the important thing.
Okay, so I personally would like to ask, like regarding the dark room test regarding RAPD. So we're not very acquainted with the procedure. Could you please enlighten us about it? Because what we usually do, all the tests are in bright daylight or maybe just in dim light. We never did it in dark room light. So if you could kindly
No,
explain for all of
yeah,
us.
yeah, you can do it in dim light also, no problem. Dr. Gyanendra, would you like to say something about this?
Please carry on.
RAPD.
It's okay.
Okay, so we have to do repeatedly swinging the
Torch.
our torch to one eye to the other. So what happened when we give when we uh, just pupillary reaction? What happens? Direct pupillary reaction, the pupil constrict. When we uh, put light on it, then pupil constrict, and when we just withdraw it, then pupil starts dilating again. So if we start swinging from one eye to another eye, first for there is a direct light reflex and there is consensual light reflex, right? So first one eye there is constriction. Similarly, the other eye also the pupil is constricted because there is a after a gingival nucleus we know there is a connection on the both sides, right? And but when you swing the if there is RAPD is present, when you swing the light to the affected eye, then instead of constriction, it will start dilating because of the withdrawal reflex of light from the other eye. That is the important thing that we have to notice.
Thank you, sir.
Is it clear or should I elaborate more?
Okay, understood, sir. Sir, there's another question in the chat box. Maybe our speaker, Gyanendra sir, can attempt this and then our chairperson will join. So one learned audience has asked, if any patient comes with methanol poisoning, however, without any visual symptom, is there any warranty of using methylprednisolone?
I don't think so. Because if patient has no visual symptom, we usually don't give any methylprednisolone.
This is the conservative toxicology management.
I think that will be nice.
Murtuja sir would like to add something?
No, it's okay. If there is no visual symptom, then you have to do nothing.
Oh,
Patient is lucky enough. He survived.
Visually
Just
stable.
tell him not
Yeah.
to go for this again.
Yes.
Luck may not favor every time.
Okay, sir. Nicely answered. And then, sir, one of our audience wants to know, is BRVO, that is branch arterial vein occlusion, mainly due to status or is it due to hypercoagulable state?
Look, BRBO, usually the predisposing main factor is your hypertension. Okay. So, when there is we all know that the varicose tracts from our MBBS pathology knowledge. So, any disruption on that, it may cause to your vein occlusion and hypercoagulable state or other blood coagulopathy usually cause BRBO in, a little bit younger as a patient. younger than 50 years. So I have one particular experience with that one. Once I was in Tibet for one screening camp, and I saw the lots of patients there with the branch retinal vein occlusion, and I took the history that do you have hypertension. They don't have hypertension, diabetic as well, but there are lots of cases of BRBO. And later on we came to know that they are all most of the time have polycythemia because they are living in high altitude. So that
Altitude.
that polycythemia lead to their hypercoagulant state, and that was the leading cause of BRBO in that region, which I have never seen in my part of this practice. So it depends upon, but hypercoagulated state is not that much common. So common predisposing factor in BRBO is in above the 50 years, it is a hypertension, diabetes are the main thing. What I have experienced in my
The multi-system diseases.
yeah.
Yeah.
Okay, sir. And then could you please enlighten us about a few drugs that may cause sudden loss of vision? Somewhere I read it could be due to topiramate, it could be due to sudden use of PDE5 inhibitors. Could you please enlighten us on the same stuff?
Yeah, I think topiramate is one of the that one. Sometimes even some anti-glaucoma medication may lead to the even anti-tubercular medicine may lead to the sudden diminution of vision. So I think this is one of the point we should ask the drug history as well in patient
Yes,
with
sir.
sudden diminution. That definitely.
Sometimes it is confusing. Ethambutol is a drug that can cause optic neuritis and a loss of vision. And some ethambutol is given is also for tubercular meningitis. So sometimes it is confusing whether the vision loss is from tubercular meningitis or from tuberculosis from the drug itself.
Very confusing.
So the main important thing to differentiate is if it is due to tubercular meningitis, then there will be disc edema will be secondary optic atrophy. But if due to drug toxicity, it will be primary optic atrophy. The secondary optic atrophy, how we differentiate, there will be features of disc edema, blurred disc margin like that. Okay, so this is important point to differentiate.
Yes, sir. Now, a very naive question maybe, but we'll take this. Like, sir, how can you differentiate between optic disc swelling and papilledema? What is the difference between, if any?
I think we have mentioned that one. Let's, for the sake of audience, I will again repeat. First of all,
Yes,
one
sir.
should understand that all optic disc swelling may not be papilloedema, but all papilloedema is the optic disc swelling. This should be the basic knowledge for every audience. That means whenever optic disc swelling is secondary to the raised intracranial pressure, that we call is the papilloedema. Otherwise, it is simply a disc edema. If there is no red, suppose in case of what we can see in hypertension, grade 4 hypertensive retinopathy, it may not be the, it's just a grade 4 hypertensive retinopathy. It may not be the papilloedema. Okay, so I think that is the basic difference to different papilloedema and other disc swelling.
Very well said, sir. Murtuja sir will add something, please.
Yeah, when papilledema, yeah, he has rightly said, papilledema is related to raised intracranial pressure. And one of the some common causes of papilledema are intracranial space occupying lesion, benign intracranial hypertension, and we must not forget about the malignant hypertension as well. So all these causes we have to exclude, and then we can treat accordingly.
And so nowadays there are a few case reports also, maybe some atypical viruses. They may also come as optic neuritis, may come with optic disc swelling, and many times may get confused whether it's an NMOSD or an MS. Even simply viral post-infectious etiologies may result. Is it so?
Your virus may cause papillitis, actually. Sometimes antiviral vaccine also cause papillitis. I have seen a couple of cases after corona vaccine as well. So this may be the scenario. And what else you asked about?
The post-infectious causes of optic neuritis, sir.
Yeah,
Can
yeah,
it be
yeah. There might be some
post-infectious?
post-infectious causes of optic neuritis, and the management procedure is almost same. And recovery is also good in such cases.
Okay, so we are almost short of time. We're almost towards the end of the session. If anyone from the audience wants to ask a live question, kindly raise hand, or we will take the last question and then move on to a speaker to end the session. Are there any live questions from anyone in the audience? If not, then I'll take the final question from the chat box. How can we differentiate between diabetic and hypertensive retinopathy clinically?
Sir will tell or I will tell? Sir, what
So
will?
both of you can.
You
Gyanendra
can
sir
tell. You
will.
can tell.
Okay, so
Yeah.
I
I
have
think you have already mentioned in your
as well, and I
presentation.
have,
Sure.
Yeah.
I think I have, this is my fourth presentation in BD Physician group. I have done both presentation on diabetic and hypertensive retinopathy. Just taking that also, I would like to say, simply the rule of thumb is hypertensive retinopathy is a wet type of retinopathy, whereas diabetic retinopathy is a wet type of retinopathy, whereas hypertensive retinopathy is a dry type of retinopathy, where you can see in diabetic retinopathy there are lots of dot blot hemorrhages and exudate, whereas in hypertensive retinopathy you see less amount of dot blot hemorrhage but lots of flame shaped hemorrhage, and arterial changes are more in case of hypertensive retinopathy, whereas venous changes are more in case of the your diabetic retinopathy. And sometimes it's very confusing, they comes as a mixed picture and we label it as a mixed retinopathy. That is I got to say. Sir, can you add please?
Yeah, if
Murtuza
you
sir
see
will add a
flame
few more
shaped,
comments.
if you see flame shaped retinopathy, flame shaped hemorrhage, then more in favor of hypertensive retinopathy. Okay, and the